We are live now, ma'am.
Sure, you can start.
Good morning, esteemed faculty members and all the delegates. Thank you for joining. Today, we are back with our series, Virtual Learning Series on Preeclampsia, VLS-PE, organized by the Society of Maternal Fetal Medicine, India. So, this is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar. And it's my privilege to introduce Dr. Anu Joseph, ma'am, who is the MOC of today's webinar. So, Anu Joseph, ma'am, has done MBBS, DNB, OBG, fellowship in MFM. Ma'am is currently consultant and medical director at Trinity Healthcare Electronic City, obstetrician and gynecologist, fetal medicine consultant at Kaveri Hospital, Electronic City, Bangalore. Ma'am's areas of interest are first trimester aneuploidy screening, screening and prevention, and high-risk pregnancy. So I welcome you, ma'am, and I hand over the session for further proceedings.
Thank you, Sahiti. Welcome one and all to the second episode of the second series of VLSPE. VLSPE, the virtual learning series, was introduced as a part of our PENAI project to make sure that the word about PE, preeclampsia, reaches each and every corner of India and now towards the world. The idea of this learning series is that we could learn about this major issue in pregnancy, preeclampsia, from the comfort of our house, and we can listen to eminent academicians from all over the world discussing on various topics which are common, rare, or a combination of both. Today, we have brought to you a combination of diabetes and preeclampsia and how it affects our mothers, our pregnancies, our children, and we would have an elaborate, almost 2-hour discussion on various aspects of it. To begin with the program, let me introduce our co-chairs of PENAI project. First of all, it's my proud privilege to invite and introduce Dr. Prakash Mehta, sir. Sir is our mentor, also the president of SFMI and the organization chairperson of ISHP World Conference. Sir is the Indian co-chair of the PENAI project. Sir would be handling today's moderation for the panel. Second, I would like to introduce Dr. Revati Rajan. Madam is our secretary for SFMI and also the Indian co-chair for Preeclampsia Education of Nation, the PENAI project. I would also like to introduce Dr. Sarosh Rana. Madam has still not joined us, but she is also our international co-chair for PENAI. All three of them together has put out this project, which has been very well accredited for spreading the word about PE throughout the world. Now, I would like to invite Sir to give his inaugural address.
Good morning, everybody, and welcome to this second episode of the VLSPE Series 2. We started VLSPE since last year, once we introduced the PENAI program in order to continue the education about the preeclampsia. The VLSPE was introduced, and last year we covered quite a few of the basic topics, including some case discussions on preeclampsia. And now in the Series 2, we are going to the next level, where we'll be discussing about the interaction and the resultant PE from the various other conditions that a pregnant patient could have. And for that, today we are going to start with diabetes and preeclampsia, and we are going to see how the diabetes and the preeclampsia interact with each other. I'm very happy to also say that today we have Dr. Kenneth Shin from Harvard, who will be joining us for a talk on anti-obesity drugs, because ultimately diabetes, obesity, preeclampsia, all the three are connected to each other. So this would definitely be a very interesting and a learning session for all of us. And welcome to all the delegates who have joined from across India and who will be watching this program on YouTube live as well as in future. And let's all have a happy learning, and let's join hands together to save lives. Thank you.
Thank you so much, sir. So now I would invite Dr. Revati to give us a capsule on what's happening in Penai.
Good morning, everybody, and thank you so much, Anu. I hope my slides are visible, full screen.
It's not in full screen, ma'am.
I don't know, it's not letting me share full screen. Can you please share this?
Well, it is the slides are seen. You can go ahead, Revati. Slides are seen.
Yeah, or Chitrakala, can you just share it full screen, please? Yes. Are we visible? Yes, thank you so much. Good morning, everybody, and thank you so much, Anu, for the kind introduction. And it gives me great pride and privilege to be talking about the Preeclampsia Education of the Nation India project. Next slide, please. This is a collaborative project between the Society of Maternal-Fetal Medicine India and the International Society of Study of Hypertension in Pregnancy. And let me take you through our saga. We started the Penai online series, which was a certification collaborative course, which started off as the online series launched on the 22nd of May 2021 on World Preeclampsia Day during COVID. And it had a lot of good responses because people were listening to preeclampsia starting from the definition till the recent advances in spite of the COVID, and they were doing it at the comfort of their offices and clinics and houses. We had about 100 plus recruits, and it was a certification course, so it had the pre-test and the post-test, which had to be complete. And post-certification, they were eligible for what is called the virtual interactive session, where they actually interacted with the co-chairs, presenting some of the most important clinical problems, which was answered live to all the delegates. Moving ahead from 2021, we launched what is called the VLS series because we found that a lot of people did not want to enroll themselves into a 6-week program. They wanted to just listen to a 2-hour program and update themselves as to what was going on in preeclampsia. And so we started the series where we conducted lectures, we held panels to update them of what was recent in preeclampsia. And this was happening every 6 weeks. So now we are on the Series-2, where we are actually looking at complex factors that can actually influence preeclampsia and how we can deal about it. So that was also launched on the World Preeclampsia Day 2022. Subsequent to this, we worked hard to get the iShip World Congress to India for the first time, and we were fortunate to launch it at the Indian Institute of Science, Bangalore and Hotel Sheraton, and it was a big super hit because we had about 420 attendees from across the world. We had 30 countries participate for this World Congress. We had about 160 original papers that were actually presented. So that was very satisfying for the society as well as its members. Moving ahead, we continued to hold the Penai program, but it was in the on-site version because at the iShip World Congress, we had the workshop version with about 60 delegates, which was a super hit because people finished learning about preeclampsia in a span of about 3 to 4 hours with a post-test certification. Tamil Nadu, a state in India, was the first state to have actually got as a workshop in its state level conference. And we had about 127 delegates, of which about 88 certified. Subsequent to that, we started putting it across societies. We recently held it at the Madurai Obstetrics and Gynecological Society National Annual Conference. We moved on to hold it at the Hubli Dharwad Society, which was actually hosted Very recently, we also did it in corporate setups like at Ovum Hospital very recently in Bengaluru. We've held it in medical colleges. We've held it in DNB institutions. We are planning to hold it in Tirunelveli very soon. With this, we have more than 600 delegates who've been recruited to this structured collaborative certification course from across the country, of which more than 400 have certified. And more than anything, the workshop is a pretext, and people continue to be associated with us beyond the workshop. So they actually discuss their clinical problems, they actually share their views about different situations, and we still handhold them beyond the workshop. So I take this privilege to launch the two sought after versions of the PENAI project. One is the iShip World Congress recordings, which include the plenaries, the lectures, the panels, as well as the oral presentations with slides, which are going to be available in the SMFMI website for conditional access for a very small commitment fee. And we have two versions that are available. One is the individual and the other is the institutional version, which is going to be launched next week for access. Subsequent to that, we also are planning to host the zonal PENAI programs. This is going to be on a webinar format. So we are going to conduct these certification courses across the north, south, east, and west zones of the country. And each format is probably going to host about 200 delegates from that particular zone of the country. We are also going global. There have been inquiries from Kazakhstan, Brazil, and other African countries to run the certification course. And we've also tailor-made it to suit the requirements of nurses and paramedical staff, as well as a program exclusively for patients called the Suraksha PE, which actually looks at patient education and empowerment. Next slide, please. So this is our data. So we have about 604 delegates who have actually been recruited to the course. We've had people from Bangladesh, UK, this was during the World Congress, as well as Afghanistan, who have actually enrolled to this course. This is the basic level 1 course that deals or starts with definition and ends with a panel, which is actually based on implementational issues. And we have about 400 odd delegates who have actually certified through the post-test assessments. Next slide, please. Yes, so we have about 200 plus delegates who attended the virtual interactive session where they actually interacted with the co-chairs, asking questions on their based on their clinical practice, which really enabled them to actually make a difference to their patients. And we had representations from across the country for this particular program. So Dr. Sarosh Rana also joined us live to answer these questions. Next slide, please. So with this, I would want to actually announce the launch of the two sought-after versions. One is the iShip World Congress proceedings, which is going to be called the PEN Update. So that is going to be active early next week for access, both for institutions as well as individuals for a very small commitment fee, which is going to be further reduced for low middle income country delegates. So all the proceedings are available and the slides can also be visualized. They cannot be downloaded, but you can use it for learning. And we've got permission from all the speakers to allow access for these talks. So that is one. And the other is the zonal webinar version, which is going to be probably launched which is going to be active starting from October this year. So with this, I would call Dr. Prakash Mehta, who's the president of the Society for Maternal Fetal Medicine India, and who's also the co-chair for the PENAI project from the Indian perspective, as well as Dr. Kenneth Chen, who is the president of the International Society of Obstetric Medicine. And he's from Harvard, and he's been our international collaborator who actually, who's been supporting us for our academics right from 2017. In fact, I give the credit for, launching our society for the first time in an international conference in 2017 in South Africa, Cape Town. So I welcome both Dr. Prakash Mehta as well as Dr. Kenneth Shen to call these courses open for recruitment and say a few words. Sir.
Sahiti, can you change the slide?
Yes.
No, the slide.
Next slide, please. Next slide.
Launch.
Yes. You can actually play the reel now, Sahiti. Can I request Dr. Prakash Mehta, sir, as well as Dr. Kenneth Shen to open these courses for recruitment and say a few words?
Yeah, good morning, everybody. I think this would be a wonderful course because it brings in all the lectures as well as some of the workshops and the papers that have been presented onto a webinar kind of a format. And this will be available to all across the world. We have kept a very special rate for the third world countries, the developing countries, and including India. I'm sure, and we are also giving an institutional discount so that we want this message to spread across as much as possible, and we hope that this webinar will be used by everybody and would be helpful to everybody. And I'm really glad that this is becoming concrete today. Thank you.
Dr. Kenneth Shen, would you want to share a few words?
Yeah. Likewise, it is a great privilege and honor for me to have collaborated with all of you on this. And likewise, I wish you all the very best with this venture. And I think everybody will be looking forward to learning a lot more from this initiative. And the best thing out of all this is that we're very confident that patient outcomes will be improved. Around the world and in your country especially, and wish you all the very best with this venture. And just on a personal note, time flies. Like I do, like I think we first crossed paths actually at the end of 2016, and I wish to just acknowledge what a great job Dr. Mehta and Dr. Ravathi particularly have done in really taking the initiative to set up your wonderful organization. Time flies, and I think you've all gone a very, very, very long way in achieving so much over the past 7.5 years, and my warmest congratulations.
Thank you so much, Dr. Kenneth. And we call these courses open for recruitment early next week. And I leave the stage to Dr. Anu to continue with the proceedings.
We have Dr. Revati with us. If should Revati Janakiraman, Madam, would you like to say something, give some suggestions?
Dr. Revati has been the past president of FOXI, and she has been a very important member she's been very contributing to the propagation of the PENAI project. Madam, can you just
thank you
something
so
about
much. Really, this PENAI program it is really an eye opener to every practitioner, and really every practitioner is now it's a nightmare. Preeclampsia and eclampsia is a nightmare to them, because in which patient it will come, in which patient what complication can arise, nobody can predict. Now this updating on preeclampsia by these programs really helps a lot to everyone, that too for the postgraduate students. And I'm very happy that Dr. Prakash Mehta and Dr. Revati have taken up this effort to spread the knowledge to everyone. I congratulate them. Thank you very much.
Thank you, madam. Thanks.
Thank you
Thank
so
you,
much.
ma'am. We have been fortunate enough to have a team of very young doctors supporting us at every step. Starting from Dr. Anu, Dr. Chaitra, and we have another 10 members who are working very hard towards helping us carry out this program. So thank you all, dear youngsters. They were my students once upon a time, but now they're all busy consultants in their own right.
Once your student, always your student, sir.
We're proud to be your students always.
So thank you all very much.
Thank you so much, everybody. It's my proud privilege now to introduce our next speaker, the most sought after for today, Dr. Professor Kenneth Shen. Sir is the president of International Society of Obstetric Medicine. He's the clinical chief of endocrinology, diabetes, and metabolism at Beth Israel Deaconess Medical Center, Harvard Medical School, Boston, and international advisor to our own SFMI. Welcome, sir, to deliver your talk on GLP-1 agonist preconceptional.
Sure. Thank you very much. If you would just allow me just about 30 seconds just to pull up my slides, okay? I'm just going to share my screen. Can I just confirm that you can all see my slides and you can hear me okay?
Yes.
Okay, wonderful. So once again, it gives me it's a great honor and privilege to present this talk today. And I also want to congratulate India on winning the T20 Cricket World Cup. Yesterday evening. Like, congratulations! Like, so you might all be wondering a little bit about why I want to talk about GLP-1 receptor agonists. And Dr. Mehta in his introduction, previewed that basically diabetes, obesity, preeclampsia are all very closely interlinked to each other. And one of the hot topics that we've all been discussing of late is the use of GLP-1 receptor agonists for the treatment of diabetes and also for the treatment of obesity. And I wanted just to talk a little bit about the recent data that have emerged relating to their use. And I want to acknowledge one of my previous fellows, Dr. Lindsay Mahoney, who actually trained under me at Brown Medical School where I was before I moved to Harvard early this year. She kind of helped me put together some of this data. For those of you who know me well, know that I like to travel, and I've put up the slide of a little village at the northern part of Italy called St. Vincent, because in 1989, October, there was a declaration that was made by a number of experts from, the IDF and WHO, and these experts got together to discuss ways in which pregnancy outcomes in the diabetic woman could approximate that of the non-diabetic woman within 5 years of that meeting. In my humble opinion, I feel like a lot has been done for the woman of type 1 diabetes in terms of optimizing or improving the pregnancy outcomes. But as we all know, the incidence of type 2 diabetes and obesity has risen significantly since that time. And over the past few years, we now often find that these women actually can be more complicated and more complex to treat even compared to the woman of type 1 diabetes. And so just to refresh everybody, I want to kind of just share a little bit of data relating to the adverse effects of obesity on pregnancy outcomes. So just, as a very quick introductory slide, I want to just remind everybody about the definitions of the BMI by the WHO in the context of, what BMI is considered normal and what is considered overweight and obese. So normal is considered between 18.5 to 24.9. Overweight is between 25.0 to 29.9. And then as you can see there, anything above 30 is considered obesity. And of course, the higher the number, the higher the class. And currently, certainly in the United States, but this is certainly true internationally as well. Like obesity is actually now the most common health problem in younger women of reproductive age. As you can see there, this is the percent of the population that is considered to be obese depending on their age groups. Okay, so for women, even for those women who are age 20 to 39, like 39.7% of these women have BMI of greater than 30. And some of the other age groups, and what is of most concern is that, like, when you actually incorporate everybody, including those who are 20 and over, like, you know, it's actually more like 41.9% of women are considered to be obese. The numbers are slightly high for men, and this is of very, very great concern to all of us who manage pregnancies. So again, as you can see, even over these past 5 years, and no doubt the numbers are even going to be worse now. Like, this was a paper that was published in the New England Journal of Medicine back in 2022. It shows that in 2020, you know, 29.5% of live births of babies were born to women who were considered obese. Okay, so 29.5%. So 15.8 of which were in obesity class 1. So that's BMI of 30.0 to 34.9. 7.9% was in obesity class 2. So that's 35.0 to 39.9. And 5.8%, okay, so more than 1 in 20 live births were born to women whose BMI was greater than 40.0, okay? And so as you can see there, this number is kind of increasing even over those 5 years. And no doubt, if we were to look at the data, you know, over the last 1 or 2 years, that there's no doubt in my mind that this number is going to even have increased even further. So what are the impacts on fertility? So obesity does lead to increased time in pregnancy. So in general terms, and I'm going to discuss this at the very end of my talk, like, you know, if we're going to have a large population of women who are going to be obese, they're probably going to end up getting pregnant even later. And so the combination of increasing age and increasing obesity is going to really potentially lead to quite a significant compounded increase in possible complications to mom and baby. So just briefly, you know, as we all know, oligo and anovulation is up to three times higher in individuals with overweight and obesity. Though, of course, there are going to be variables that affect this, particularly the, you know, the increasing incidence of PCOS as well. But that being said, you know, data has shown that anovulatory infertility increases of BMI regardless of whether the patient has PCOS or not. And a couple of studies in the US and in the Netherlands. So the US cohort study of greater than 7,000 individuals demonstrate that there are decreased pregnancy rates even with regular menstrual cycles. And again, in the Netherlands, a study of greater than 3,000 women also confirmed that women with regular menstrual cycles, you know, that the rate of spontaneous conception are going to be declined with increasing BMI, okay? So, sorry, I'm just trying to advance my slide. Sorry. So, anyhow, so obesity has also definitely been associated with worse outcomes in infertility treatments. And this is probably related to decreased ovarian responsiveness and the fact that the individuals with obesity tend to require high doses of gonadotrophins for ovulation induction. And there is quite a bit of data to confirm that, you know, with obesity, because of the pro-inflammatory milieu and environment due to insulin resistance and inflammation and so forth, the oocyte qualities are going to be decreased. Okay, now there are a lot of adverse outcomes that are associated with obesity, and this slide kind of summarizes all of them. I'm going to concentrate on a couple of these things because, you know, like, honestly, going through all of these adverse outcomes is a whole lecture, a whole hour-long lecture in its own right. But I want to just kind of highlight that, you know, not surprisingly, you know, these are the relative risks that we see with in terms of adverse outcomes associated with obesity. So in preeclampsia, the relative risk is like 3.57, and I'm going to spend a bit more time on the data relating to this shortly. Gestational diabetes is not far behind at 3.34. Postpartum infections, again, 3.34. And as you can see there down the bottom here, all of these things are significantly increased, okay, including early pregnancy loss, of course, macrosomia, stillbirth, spina bifida, preterm birth, failure of labor to progress. Okay, so that and that in itself is very closely linked to the increased rate of cesarean sections. Postpartum hemorrhage is also increased, and also postpartum depression. Okay, so again, this was highlighted in quite a lot of detail in the paper that was published in the New England Journal of Medicine in 2022. So let's specifically talk a bit about preeclampsia, okay? So we all know that preeclampsia generally occurs in about 10% of people with pre-pregnancy obesity. And, you know, when we look at like systematic reviews of a number of cohort studies that total 1.4 million people, the risk of preeclampsia seems to double with each 5 to 7 kilogram per meter squared increase in pre-pregnancy BMI, okay? And the rate of preeclampsia is in fact 3 to 4 times higher in class 2 or class 3 obesity, even when the BMI is greater than 35 compared to class 1, which is where BMI is between 30 to 34.9. And this was actually published in the American Journal of Obstetrics and Gynecology in 2019. So as you can see there, obesity has a great impact on preeclampsia, which is, I guess, you know, what we're all certainly interested about. And in my mind, I think if we're able to improve the rates of pre-pregnancy obesity and BMI before pregnancy, this is going to go a long way to reducing the risk of preeclampsia. This is a slide that basically summarizes in terms of neonatal outcome, the risks of congenital anomalies relating to that we see in obese versus non-obese mums. Okay, so specifically, again, you can see that all the odds ratios are increased, but specifically for spina bifida is more than twice the likelihood of spina bifida with mothers who are obese. And then of personal interest to myself is the fact that, you know, even with all the medical technology advancements, if we're dealing with populations that are more overweight and more obese, this is going to lead to a lot of downstream complications for future generations because, you know, various studies have shown that there is an increased likelihood of childhood obesity with preconception maternal obesity. The odds ratio is 3.64. And even with mums who consider overweight, so this is BMI between 25 to 29.9, the odds ratio is still 1.89. So, and as we all know, you know, like a lot of you know, a lot of the medical conditions that we've been treating over the last you know, a couple of decades, we've all gone a long way in learning a lot about how to treat them, and we've learned about improved outcomes. But if we don't deal with this obesity epidemic, you know, we're going to have a lot of you know, issues to deal with for future generations. And this author actually used to work at Brown Medical School while she was a pediatric endocrinologist, and she published a paper actually even going back 20 years almost, that showed that even at that time, the preconception maternal obesity almost doubled the risk of metabolic syndrome in children. So a lot of this data dates back quite a long time. But the bottom line is that, like, you know, with you know, again, you know, the increasing incidence of maternal obesity, there's no doubt that the future generations are going to have more issues to deal with in that context. So currently, what are the guidelines that exist in terms of managing obesity in pregnancy? So the American College of Obstetrics and Gynecology in 2021 published some guidelines that, you know, and I might just summarize the main one. Like, I think here, you know, the guidelines said that, you know, even though achieving a normal BMI is the ideal, it is going to be very difficult for a lot of women to achieve this. And so what they kind of concluded was a weight loss of 5 to 7% over time can still significantly improve the metabolic health. And, you know, the US Preventive Services Task Force, which kind of looks at all these practice guidelines, recommends that all adults age 18 or above with a BMI of greater than 30 be offered or referred to intensive multi-component behavior interventions for weight loss and weight loss maintenance. Now, interestingly, this particular guideline stated that medications for weight management at that time, and this was published a few years ago, was not recommended in pre-pregnancy time or during pregnancy because of safety concerns and adverse effects. But that being said, I'm about to kind of discuss some recently published data since these guidelines were published that suggest that, like things may not be quite as dire as this statement potentially describes. Now, in FIGO 2020, they also kind of published some guidelines, and please note that there were contributors from India as well, in this context. And basically, a number of recommendations were made, and one of the things that it kind of highlighted was that weight management strategies prior to pregnancy can include actually all of these things, okay, like dietary interventions, exercise interventions, medical therapy, and surgical approaches. So surgical approaches, we're talking about bariatric surgery, and in the interest of time today, I'll mainly concentrate on the medical intervention, because again, each one of these modalities are a talk in itself. It's suggested, of course, that, and this is kind of, I guess, not unexpected, that diet and exercise should be considered the cornerstone of weight management. But, but this guideline is clearly insinuating that, the next step beyond that might be medical therapy, because surgical therapy should probably, in broad terms, be reserved for patients who don't actually do well enough with the medical therapy. Because as we all know, surgical approaches, particularly that of gastric bypass, potentially a lot of complications relating to malabsorption and, can occur. And again, we can discuss this in question time if we need to, but a lot of babies born to moms who've had gastric bypass surgeries have been documented to be a little bit smaller for gestational age, and our sense is that it's probably related to some of the malabsorption issues that we come across. And again, this is from the American Society of Reproductive Medicine. I think maybe the key thing to note here is that the weight loss intervention trials with obesity and infertility have not necessarily shown an improvement in the outcome of live birth after treatment. However, weight loss definitely improves the chance of an assisted conception, from their experience. So again, we could spend a lot of time looking at the details of these guidelines, but I feel that I probably should really get to the main point of this talk, which is to talk a bit about GLP-1 receptor agonists. And I will just kind of, summarize the positive points relating to lifestyle interventions. Okay, so lifestyle interventions basically are generally effective in achieving pre-pregnancy weight loss. Okay, and it seems to increase ovulation and pregnancy rates. It probably improves in rates of GDM, but we usually need to couple it with early screening. It probably improves the rate of hypertensive disorders in pregnancy and preterm birth as well. But a couple of things is that the lifestyle interventions, broadly speaking, the studies have not shown a consistent improvement in pregnancy rates compared to immediate fertility treatment. And again, there didn't seem to be consistent differences in live births after preconception weight loss just with the diet and exercise interventions alone. And there was also no clear difference in terms of early pregnancy or loss rates. Okay. But in terms of preeclampsia, which again, which all of us are interested in, it seems that there probably is an improvement of that along with gestational diabetes. Okay, so let's talk a bit about GLP-1 receptor agonists. So I'm going to now highlight some studies that have been published in the last few years looking at, looking at the use of GLP-1s, receptor agonists. So this paper that was published in the European Journal of Endocrinology in 2018 looked at the use of liraglutide, which is the daily dose of GLP-1, and it used to be known as Victoza. And basically, this is a fairly small pilot study of 28 women with obesity, PCOS, and infertility. The treatment group basically received a little bit of liraglutide, 1.2 milligrams daily, and metformin for 12 weeks before they got they were treated with IVF, and the control group was just metformin alone. And interestingly, there was not much significant difference in the weight loss between the two groups, though the pregnancy rate per embryo transfer was significantly higher in the liraglutide group compared to metformin alone. And there was an increase in cumulative pregnancy rates over the 12 months, probably about double with the use of liraglutide and metformin compared to just metformin alone. Okay. Now, and then another study that was published around about that time looked at exenatide, and exenatide is probably the GLP-1 receptor agonist that first came out on the market. And bear in mind that the half-life is actually very short for exenatide. Okay, in the US, it's not really used very much anymore because it's since been superseded by not only liraglutide but the semaglutide, which is typically only given once a week. And this randomized control trial involved quite a lot more women, and the treatment was basically exenatide and control was metformin. And basically then at week 13 onwards, they were just treated by metformin. And interestingly, during the first 12 weeks, there was greater weight loss in the exenatide group compared to metformin only. And during the second 12 weeks, the rate of spontaneous pregnancy in the treatment group was significantly higher than in the metformin group. So even though by that time the exenatide had stopped, the rate of spontaneous pregnancy was still higher compared to the group that was only being treated with metformin. So basically then they extended the study to look for longer, and they kept following these two groups, and if they didn't conceive spontaneously during the 12 weeks on just metformin, IVF and various other modalities were offered until the end of 64 weeks. So this is well over a year. And interestingly, at week 24, about double the number of women in the exenatide group conceived spontaneously compared to 14.7 in the metformin-only group. Okay, so about double, for the people who actually just stayed on the exenatide. At the beginning, they again seem to conceive, more of them conceive spontaneously compared to the metformin-only group. Okay, so now by 64 weeks, however, the pregnancy rates were then actually became quite similar, interestingly. And then again, when we followed these women up until 64 weeks, by that time, there was no significant difference in the pregnancy outcomes between the two groups. And interestingly, there was no difference in gestational weight gain. So basically, the conclusions that we can make are that if we were to use a GLP-1 receptor agonist, the greatest impact on the outcome was towards the beginning, of the treatment window. And if we kept following these women for long enough, eventually it seems like the outcomes were very similar. So I guess in summary, the big point to note there is that if the women were to use a GLP-1 receptor agonist, it looks like they would get the maximum impact on the outcome early on. And then last year, this group basically did a meta-analysis and systematic review looking at the effects of GLP-1 receptor agonists on women with obesity and PCOS in terms of the weight and metabolic outcomes. 11 randomized control trials were included. And in terms of the pregnancy outcomes specifically, the GLP-1 receptor agonist use was associated with improvement in natural pregnancy rate, okay? So the relative risk was 1.72. So it seems like, using these the improvement in natural pregnancy rate was about 1.7 times as likely. But interestingly, there was no statistically significant difference in the total pregnancy rate or the IVF treatment rate of its use. So it seems like, again, we can conclude that, like using this therapy, it seems like women are going to, if they're going to have a positive impact and a positive outcome, it's going to occur very early to the extent that they didn't even need to then proceed to IVF pregnancies. And once again, the longer that you follow them for, if they end up needing to, go into IVF and so forth, then there was not much statistically significant difference in the total pregnancy rate between the two groups. So once more, if we were to use these, the impact is by far the most positive and impactful at the beginning of therapy. So let's kind of go through the key points. So in summary, the current data is a bit limited to these women with overweight and obesity, and the preconception treatment with the GLP-1 receptor agonist likely increases the rate of spontaneous pregnancy, but there did not seem to be much of an improvement in IVF pregnancy rates, and interestingly, there wasn't much difference in the pregnancy outcomes. When we extended looking at all of these women who we followed. So probably the biggest, I've said this a few times already, but probably the biggest impact is on the women who take it. They're super sensitive to it. They do really well. They get pregnant quickly, and then it seems, and then they conceive naturally, and then these are the ones who don't end up, getting as many complications as the other cohorts. Now, one of the controversial things, I guess, of late is, when do we tell women who have been on GLP-1 receptor agonists to stop these agents before they attempt pregnancy? And currently, the guidelines where I work is that we should, if somebody's thinking about getting pregnant, we should stop the GLP-1 receptor agonist roughly about 2 months before they attempt to conceive. And this is largely based on data on animal studies where the GLP-1 receptor agonists have demonstrated an increased risk of, embryonic death, fetal growth restriction, and congenital anomalies, particularly delayed ossification and skeletal variants. Okay, like there's a study that was published by Muller et al. In 2023 that looked at a lot of pooled data from animal studies, and and that study, by the way, it not only looked at GLP-1 receptor agonists, it also looked at SGLT2 inhibitors, which are now more and more commonly used in younger patients of type 2 diabetes that are not well enough controlled on metformin alone. Okay, so that study looked at the use of both the GLP-1 receptor agonists and the SGLT2 inhibitors, and it seems that in the animal studies, both of these agents are cause various issues. Now, that being said, they've since that time, a number of case reports have been published, and dulaglutide, otherwise known as Trulicity, there were 2 case reports that were published in the last 2 years. Okay, so the first one was one where it was stopped, like it was actually basically continued throughout the whole first trimester because that patient didn't know that she was pregnant, and when she found out she was pregnant, the dulaglutide was finally stopped at 15 weeks. And the outcome of that patient was that there was gestational hypertension that was diagnosed at 35 weeks, but and had an emergency C-section for a non-reassuring heart rate at 37 weeks. And there were no congenital anomalies, and the baby was of normal birth weight. Okay, so it was gestational hypertension, but it did not reach preeclampsia at any point. And in 2023, again, dulaglutide, again, the lady did not realize that she was pregnant, and so it wasn't stopped until 3 months. Again, there was elective repeat C-section 38 plus 4, no complications. There were no major congenital anomalies, but there was very mild bilateral renal pyelectasis that was noted. So again, we don't quite know whether that might be related to it or not, but there were certainly no major congenital anomalies. With semaglutide, there was one case reported last year that was, where the weekly injections would continue until the lady found out she was pregnant, and so it was stopped right, just before 4 weeks gestation. And she had a vaginal delivery at 41 plus weeks. it was not discussed extensively whether she had documented gestational diabetes or not, but reading between the lines, I think it's quite probable that she did, because like she had undiagnosed gestational diabetes because the baby had macrosomia, shorter dystocia, and some neonatal hypoglycemia. But the baby was followed at 6 months, and there were no developmental anomalies and no other congenital anomalies and so forth. Liraglutide, just briefly, again, no specific complications that was noted, and interestingly, exenatide, it's been documented there seems to be minimal fetal transfer in a single placental study that was published last year. So this is all the data that's out there. I think basically, we all can still continue to want to get more experience with its use. And I think, so right now, I think, in summary, we at the moment are still telling patients to, if we know that they're on these things, to tell them to try to stop them about roughly 2 months before they get pregnant. Now, all this being said, this paper was published, last year in JMA Internal Medicine, and this was an observational cohort study that was done looking at the use of second-line anti-diabetic medications during the first trimester of pregnancy and the risk of major congenital malformations. And I might just kind of jump straight to the conclusion that the results did not seem to indicate a large increased risk of major congenital malformations above the risk conferred by maternal type 2 diabetes requiring second-line treatment, okay? Now the thing to note about the study is that when they did the study, one of the parameters they used was which women had refilled a script around the time that they conceived, okay? Now, so they only looked to see what scripts were actually picked up and refilled and picked up at the pharmacy, but they did not go as far as actually checking to see whether the women were actually taking these things at the time of conception or not, okay? So that's the biggest drawback from this observational cohort study. And I think there is no doubt that we need to get more data relating to this. I only have a couple of minutes left, so I'm just going to kind of lastly finish up by just bringing up a broad point that, all of us may come across, that, for women who are older, do we try to get them to avoid pregnancy until they achieve weight loss? Or how do we balance the risk and benefits of pre-pregnancy weight loss of aging? And so I want to kind of just highlight that, this is a bit of I guess, a clinical dilemma for us, because, as we all know, pregnancy rates and live birth rates, are reduced of increasing BMI. But at the same time, if the woman comes to us already being a little bit older, what is the impact on optimization of the pregnancy outcomes? And I want to jump straight to this table now, which highlights, for some reason, oh, here it is. My mouse is now working. And I want to highlight a couple of critical points, okay? So basically, this table highlights, the cumulative likelihood of live birth rates for somebody in the top line, for somebody aged below 30 who has a normal weight, BMI, there's a 64% cumulative likelihood of live birth weight, okay? Sorry, my mouse is not, oh, here it is. And again, here it's an example for somebody who's age 37, the rate of life accumulation birth rate is about 35% for somebody with the BMI. And as you can see here, by the time you get to a high age, these are very low rates. And particularly when you get towards the higher BMI. Now, note as an example that in the same class obesity, between the age of 37 and 38, the rate drops off significantly. So I guess we have to just balance all of these things when we see these women. And then, of course, I think what I'm alluding to now is, of course, the earlier that we intervene, the better, okay? Because when they come to us very late, if we were to spend a long time trying to get them to reduce the weight, it may not be possible to necessarily improve the cumulatively live birth rate. And so therefore, it's best for us to try to deal with the metabolic issues relating to these women at a younger age so that the outcomes can be optimized. So a number of references were used, and this last slide just show a success story of one of my personal patients that I looked after during the pandemic, whose preconception BMI was greater than 40, and I was able to use diet, exercise, and these GLP-1 receptor agonists to improve her preconception BMI, which was actually almost about 50. Okay, like it was about 49.8 or something like that. We managed over about 12 months to get her preconception BMI from 49.8 down to I think about 37.3 or something like that. And I think we're able to achieve that just with diet, exercise, and GLP-1 receptor agonists. And she ended up having a very good outcome. We were able to keep her weight neutral throughout her whole pregnancy. She did not get gestational diabetes. She did not get preeclampsia. Had a very good outcome. And this was me holding her baby when I went to visit them to get her in the postpartum floor. So I've actually run a little bit over time. So at this point, I'm happy to take any questions from anybody.
Yes, some of our participants have sent in a few questions. Can we continue GLP-1 analogs after confirming pregnancy? I think you've answered it, but yeah, there is a question.
Yeah, okay, let me look at the chat box. Oh, sorry, were you not able to hear me very well? I'm sorry. So can we continue GLP-1? So the second question, does it mean that pre-existing endothelial dysfunction can still continue to affect without significantly? So yeah, Dr. Bravati, do you want to just, qualify your question? So okay, I'll try to answer it, and please interrupt me if you don't feel like I've answered. So basically, ultimately these women all have a fairly pro-inflammatory milieu, and I think like using these agents on its own right will not necessarily improve the inflammatory milieu significantly. I think, what we try to get these women to do is that we get them to, as an example, eat healthily, like eating like a Mediterranean diet, which is strong, high in antioxidants, fish oil and various other things like that. And you may recall a few years ago, I gave a talk talking about the use of malonocitol, which tends to improve insulin sensitivity. So all of these things will probably improve the inflammatory milieu. So these agents in its own right, probably in it by themselves won't improve the inflammatory milieu, but it has to be in conjunction with a whole, various other things. Okay, so and we can discuss that a little bit more, but I would say that it needs to be done certainly with all those other things I just pointed out. Does it have a rebound effect once stopped? So that's a very good question. So there are a number of patients that we term as being more sensitive to these agents than others. Okay, so the ones who respond very, very well initially to these agents, we do tend to see them have a rebound effect once we stop these agents. Like some of these women who are very sensitive will then put on weight quite quickly once we stop them. So that's probably the reason why my personal thinking is that's probably why as you can see, the women, the ones who respond best to conceiving quickly and so forth are the ones that get pregnant fairly quickly, like fairly soon once they've been on these agents. Because I think once you stop them for a while, and then like we saw in those studies, like if we kept following them, the longer and longer after they've been off, they don't respond as well, and it's probably due to the fact that the body no longer is as sensitive to insulin as they were when they were on these agents. And the fact that probably they start putting on weight again. I think that's my personal theory as to why that is, because there is definitely a rebound effect once it's stopped. So grossly obese pre-pregnancy, I think it's worth at least trying them on the medications first. And look, by all means, we may need to kind of go to surgery. But I generally would want to see at least how they respond to the medical therapy. This case I shared at the very end of my talk was somebody who we felt like probably needed to, at the beginning, needed to go to surgery, but she proved us all wrong by responding very, very well to diet, exercise, and just the medications alone. Because the issue is that, like I said, for the patients who end up getting, particularly going to the bypass surgery, they can get a lot of other effects. And bear in mind that actually occasionally we actually have had to even get these women to have reversals of surgery, because then they have to bypass, and then they can't eat anything, and they can't actually, in fact, get enough nutrition, even for the pregnancies. We've had people who actually, sometimes don't do very well, once they have that. And in fact, I came across a case early this year where this woman actually ended up losing her baby because she just was not able to absorb any of her nutrients at all. And and on top of that, she got hyperemesis in early pregnancy, and she has had a couple of early pregnancy losses, and she's now requested a reversal of her bypass surgery. I'm looking at the rest of the questions.
So apart from pregnancy, if a woman takes, how long can we continue it?
Sorry, like how long can we continue the
GLP-1
medication?
agonist.
Yeah, okay. So I think the guidelines, like I said now, are that if somebody is planning a pregnancy, get them to stop at 2 months, roughly 2 months before they get pregnant. This is with the weekly semaglutide, okay? If they were using the shorter acting agents, you can probably stop them a bit sooner because the half-life is a lot shorter, okay? So exenatide, the half-life is actually only about 3 or 4 hours, and liraglutide, the half-life is, about 24 hours. With semaglutide, it tends to be a fair bit longer. So the guidelines currently tell us that we should stop at about 2 months. But like I said, it seems that just broadly, when we speak to colleagues who've used a lot of these agents and who have a fair bit of clinical experience, it seems like some women who have fallen pregnant on these things, when you follow the babies, they seem to overall have not done particularly badly. Okay, and like I said, that include, like, there are some case reports that have been formally published, but when you talk to people in the certainly in the endocrine society and I'm trying to think of it's not the obesity society, but there's an organization where a lot of obesity experts meet on a regular basis. When we talk to each other, it does not seem like people who actually conceive have done particularly poorly. And I think probably in the next 12 months or so, there'll be more data that's going to be published that show that there isn't, that the adverse effects are not as high. And curiously, again, getting back to the context of preeclampsia, there are a couple of groups around the world who are looking to see whether ongoing use of GLP-1 receptor agonists throughout pregnancy may actually also decrease the risk of preeclampsia, as well. So there are a couple of groups that are actually studying this in a bit more detail. So we'll look forward to seeing what the results show.
So regarding the IVF part of it, the question is, can we go ahead with egg pickup, that is ovum pickup, while the patients are on semaglutide, and stop medication 2 months before embryo transfer? So does it matter during ovum pickup if the woman is already on GLP-1?
I think that seems fine, because like I said, the studies were shown that no. So basically, the answer to the question is that the thinking is that certainly during the oocyte retrieval and the embryo transfer, that this should not be a problem with the patients being on it. So that is definitely right now what the reproductive endocrinologists are doing. Yes. Yes.
Termination of pregnancy may not be indicated for accidental exposure in the periconceptional period. Can you please elaborate on that?
Yeah, sure. So like I said, like so far the case reports and the anecdotal evidence do not suggest that there is enough compelling reason to actually terminate a pregnancy just because somebody was on these agents at the time of conception. Certainly not. It's interesting, like perhaps I can just digress a little bit and talk a bit about the situation with the use of steroids. Like, I don't, as those of you may recall that back in the 1970s, there was some concerning data that, women who are on steroids at the time of conception, there may be an increased risk of cleft lip and cleft palate to babies, right? Like, this was back in the 70s, right? And really since then, our clinical and anecdotal experience has been that women who conceived on steroids or who are taking the steroids in the first trimester do not have an increased risk of those conditions. So my humble opinion is that I think probably it is a very similar situation that we're seeing for these agents. Like again, I do want to acknowledge I think it's good for more data to be published and to come out. But again, when I talk to various other, I guess, people and groups who do a lot of this work, our thinking is that it's probably not going to be a big problem. And the next thing is to, again, that's why I included that last study about the placental transfer of these agents from mom to baby. I think it'll be best for us to quantify how much of these agents actually get across the placenta to the baby. And I think once we can quantify this a bit more and a bit better, we're going to have more of an idea of how much effect it possibly might cause the babies. And of course, once we get these data and once we get these studies, we will want to probably use and choose the agents that tend to cross the placenta the least, right? So that way we optimize the mom's condition and, whilst minimizing the exposure of the fetus to these agents.
The last question that's put in the Q&A session is it available in India? Yes, it is available in India.
Yeah, I actually could one of you tell me like which are all of these agents available or only some of them available? Because I haven't even talked about the tirzepatide, which is the new combined GLP-1 receptor agonist and the GIP-1. I haven't even talked about that one, but because that one is relatively new. But basically is semaglutide, is it readily?
Yes, sir.
Okay, all right. Okay, so yeah, any other questions like?
Dr. Tilak is joining in as our panelist. He's an expert physician in obstetric medicine. Dr. Tilak, Dr. Revati wanted to take up that question. Is it available in India?
Yeah, it's available, ma'am. Semaglutide and liraglutide. Liraglutide injection, semaglutide tablets. It's available.
Thank you.
Thank you.
Any further questions? So can we go ahead with the panel?
Yeah, thank you, Dr. Kenneth. For those who are not aware of it, I think it's almost approaching midnight for Dr. Kenneth, and he has stayed awake specially for us to be a part of this panel. Thank you very much for that, and we hope to have you on future programs too.
Thank you so much, Dr. Kenneth, and thank you so much for participating in the launch. And we really appreciate your patience as well as your effort to put in these slides. I'm sure we're going to be connected further. Thank you.
Okay, all right. Have a good night. Oh, have a good rest of the day, everybody. Okay, take care. All right.
Good night, sir. Thank you.
Okay, bye-bye.
Bye.
Moving on with the much awaited next program, the panel discussion. I have always felt that every VLS series, we do bring upon newer concepts. We do bring upon newer ways of thinking into newer concepts, how we can utilize things which are being approached in a new way. For instance, today, the GLP-1 agonist, how much can we use it in our obstetric gynec fertility practice? Similarly, the panel discussions at every VLS series has been an eye-opener to our day-to-day difficulties that we face. And Dr. Prakash Mehta sir has been an eminent person in bringing about the case discussion in such a way that, you will always think, oh, I did have this patient. And yeah, probably I should have done it this way. The outcome would have been a little better than what we had. So inviting Dr. Prakash Mehta sir to moderate the next panel discussion on the interaction of diabetes and pregnancy, diabetes and preeclampsia and pregnancy. And to join him as a panelist, I would like to invite first Dr. Revati Janaki Raman, Madam. Ma'am, welcome to the panel. Madam has been the former director of IOG Chennai, Vice President Foxy South Zone in 2016, President TNFOG 2023, and Madam has been a very loud person regarding the teaching to the youngsters, postgraduates, and has conducted many programs in this regard and contributed to chapters. Wonderful teacher, and the Pride of Foxy Award has been bestowed on her in November 2019. Welcome, ma'am. Next on the panel, I would like to invite Dr. Narahari Agasti. Sir is joining us all the way from Bhubaneswar. Thank you, sir, for joining us. He is MBBS MD, fellow in minimally invasive surgeries. Sir has had multiple publications and various international and national journals, and he is also a teacher and an examiner to various different universities for PG, UG, and DNB programs. Thank you, sir, for joining us. Next, I would like to invite our own Dr. Chaitra Satyanarayana. Dr. Chaitra is a consultant OBG with special interest in high-risk pregnancy and reproductive medicine. She's practicing at present in Bangalore, Genia Fertility Center. Has been a very great volunteer and support person at SFMI. Welcome, Dr. Chaitra.
Thank you so much.
The next, we've been already introduced to Dr. Tilak, who was answering our question on GLP-1 agonist. Dr. Tilak is consultant physician and geriatrician at Shanbag Hospital, and also the consultant physician at Mirror Health, Basavishnagar. His area of interest is in diabetes as well as obstetric medicine. Welcome, Dr. Tilak. Sir, I hand over the mic to you.
Thank you, ma'am.
Starting of the panel.
Thank you for that wonderful introduction. I'm sure by now we realize that most of our panelists are all absolute experts in their field. And I'm sure we have got people from across the country, and this panel will be definitely an eye-opener. The panel is about an interplay between preeclampsia and diabetes. So we have preeclampsia, we have diabetes. How are they connected to each other? Are they causing a problem for each other? Are they increasing the incidence? Does diabetes cause more problems with preeclampsia? Does preeclampsia cause more problems with diabetes? That is the crux of today's panel discussion. And I'm sure with this wonderful panelists, everything will become crystal clear. Now, hypertensive disorders in pregnancy and diabetes are two important maternal cardiometabolic disorders. By now, we have realized that these are not just pregnancy-related disorders, but they cause problems even for the future. And so both these problems are what we term as cardiometabolic disorders. And they result in a large disease burden for the pregnant individuals worldwide. Today, I'm sure you will hardly have an OP where you don't have a diabetes or a hypertension coming in. There are major health-threatening problems because they have high prevalence and have high adverse effects. And as per WHO, these two together are involved in 40% of maternal deaths. So just imagine if you are able to control these two, our mortality rates or even our morbidity rates will come down by almost 40%. Now we'll just go to the basics first and then we'll go further. So to Dr. Revati Janakiraman, what is preeclampsia and how common is it?
Well, gone are the days when we thought that the preeclampsia is just a hypertension with proteinuria. Now we clearly understand that it is a multi-system progressive disorder characterized by the new onset of hypertension and proteinuria, or new onset of hypertension plus significant end organ dysfunction with or without proteinuria, typically presenting after 20 weeks of gestation or postpartum. It is becoming very, very common that the maternal morbidity and mortality, the fear about all these things is now overtaken by, from PPH, it is overtaken to PIH. And the incidence is around 5 to 15%. And actually, the recent incidence I noticed in our government Rajaji hospital last month, it is 13.6% of the pregnant women.
Absolutely. So preeclampsia, the definitions are changing, the incidences are changing, the complications are changing. The next basic question to Dr. Narahari, what is diabetes? What are the types and how do you diagnose them? Just in a nutshell, so that we build a platform to go further.
Sir, at the outset, it's my heartfelt thanks that allowing me to, as a panelist, to share my thoughts on this non-communicable disease, which is becoming a very larger magnitude day by day. Coming to diabetes, the diabetes may be a type 1 diabetes, may be a type 2 diabetes. Type 1 diabetes from the early juvenile onset may be absolutely deficiency of insulin. And also in type 2, that is a late onset, adult onset, that is maybe due to insulin resistance. And particularly coming to my subject, that is as obstetricians, that is a gestational diabetes mellitus, that is the onset of diabetes first time during pregnancy, which is detected, it was not earlier detected. So these are three categories that we encounter in our society. And as obstetricians, what happens, I am seeing the increasing prevalence of gestational diabetes mellitus day by day, may be due to environment factor, may be due to lifestyle factor. And also it has a short-term effect, it is a long-term effect in the sense that you have already told it is a cardiometabolic or vascular metabolic disorder. So that is my perception as obstetricians in this field, sir.
Absolutely. So by now we know that India is the diabetes capital.
India capital, sir, because there is a reason for this, sir. Because what happens, for the insulin mechanism, we want two tissues. One is skeletal muscle, another is liver, basically. But we Asian Hispanics are sarcopenics in the sense we are less in muscle mass, but more in fat, that is visceral fat. And visceral fat itself, it causes a insulin resistance. So that may be the reason why we are having a much more incidence of diabetes in Asian Hispanics, especially Indians.
Absolutely. Now we go to the next question. Again, back to Dr. Narahari. What is the incidence of preeclampsia in diabetes? Is it the same as a normal patient, or do the diabetic patients have a higher incidence of preeclampsia?
Definitely, sir, it is a higher incidence, but it is related to vascular pathology. What is preeclampsia? What is the correlation between these two metabolic disorders? There is a pathogenesis is same. What happens? First, there occurs a oxidative stress. Then there is release of inflammatory mediators and much more. And third, there occurs a vascular endothelial damage. So the correlation between diabetic and preeclampsia very much high, and also the increased prevalence of this preeclampsia, especially if there is a pre-existing disease of GDM or type 2 diabetes or type 1 diabetes.
Absolutely. So the diabetes, the preeclampsia in diabetes almost twice that in
Yes.
a normal patient. And
Yes.
of course, we know that glucose intolerance in the later week of pregnancy is associated with gestational hypertension and also hyperlipidemia.
Yes, sir. Because as the pregnancy advances, the diabetogenic hormone that is mostly human placenta, lactogen, cortisol, estradiol, all are being secreted by placenta, and itself it is a diabetogenic state. So that is the reason why incidence increases.
Absolutely. Now let's look at the picture from the other angle. Madam Dr. Revati, what is the incidence of diabetes in preeclampsia? Is diabetes more common in preeclamptic as compared to a normal patient?
Yeah, actually, the diabetes and preeclampsia go hand in hand. Previously, we used to teach that whenever there is a disease in pregnancy, effect of disease on pregnancy and pregnancy on disease. Now we have to discuss about the two diseases or two disorders and their impact on each other. And women with preeclampsia exhibit the insulin resistance. That is very, very important. And they show a twofold increase of developing diabetes when they are followed up for more than about 10 to 15 years. So that is very important. And gestational diabetes and preeclampsia, when you see, gestational diabetes is a risk factor for preeclampsia during pregnancy, while preeclampsia may cause diabetes later in life. The moral of the story is, when there is a history of preeclampsia during pregnancy, it should alert the clinicians to the need for preventive counseling and more vigilant screening for diabetes. That's very important.
Absolutely. So I think let us all make it a definite habit that whenever you have a history of preeclampsia in any patient or even a gestational hypertension, please look for diabetes in this patient. You'll be surprised as to how many so-called normal patients turn out to be diabetic. And this is one graph which shows what is the relationship of preeclampsia with diabetes, and you can see that if there is a gestational hypertension plus GDM, the incidence of cumulative probability of diabetes mellitus later in the life, anywhere between 10 to 15 years, is increased. Now, next question goes to Dr. Chaitra. Does diabetes and preeclampsia have common risk factors? If I have a risk factor, can I presume that, okay, this patient may have diabetes, this patient may have preeclampsia?
Yes, sir. So as we all said, diabetes and preeclampsia are cardiometabolic problems. They stem from common risk factors. And I think two risk factors that we must remember as we see in our clinical practice where these two diseases coexist. One is obesity and the other is advanced maternal age. We definitely see that this population of our patients end up with both the disorders more likely than having any one of them. When we look at obesity, as we've already had so much of talk about GLP-1 agonists, high pre-pregnancy BMI is a major risk factor for both these problems, as well as gestational weight gain. Increased gestational weight gain is a common risk factor for both the problems. And apart from this, we have factors like genetic susceptibility, etc. But when we look at the lifestyle problems, like when we have lifestyle factors, especially like lack of exercise or dietary alterations, then these women are prone for both the problems. The other major sector or risk factor is advanced maternal age. As we all know nowadays, as pregnancies are getting postponed, we have women who are elderly, and that's one of the challenges that we have. If we have to give them enough time to lose weight, the clock ticks and then their reproductive potential starts dropping. So it is a very difficult and tight, delicate balance that we need to have, especially in the elderly and the obese. Nevertheless, lifestyle changes will make a difference. There are some factors, of course, like multiple pregnancy and PCO, which, according to this table, have been put across in different columns, as in they may not overlap, but we have seen in clinical practice that PCO, multiple pregnancy, all of them have a higher incidence of both these metabolic problems, and this is because they share a common pathophysiology.
Thank you, Dr. Chaitra, for a very clear elucidation. The next question again comes to you. Does diabetes and preeclampsia have a similar pathophysiology?
Yes, since we have already been discussing, both these diseases do share a common pathophysiology. And I think it is a two-stage process, which we have always been studying from our UG days. So one is placental ischemia. When we talk about preeclampsia or diabetes, it is placental ischemia, probably because there is inadequate endovascular trophoblast invasion and spiral artery remodeling. Then there is this oxidative stress component, which causes all the cascade of events. So there is endothelial dysfunction and there is the maternal immune response, which causes the endothelial dysfunction, thereby causing preeclampsia as well as diabetes. If we just want to look at each of them individually, when we talk about diabetes, basically, whether it is type 1 diabetes or the later onset of gestational diabetes, there is impaired trophoblast invasion and spiral artery remodeling issues even in diabetes. We also know that there is something called as neutrophils. Basically, there's something called as neutrophil extracellular products, and these are increased in cases with women with diabetes, and they also cause impaired spiral artery remodeling as well as intervillous space occlusion. Again, oxidative stress is a major problem. This causes increased reactive oxygen species, decrease in the nitric oxide, basically, which is a vasodilator. So there is vasoconstriction. And along with this, there is also advanced glycation end products or AGEs, which is seen with diabetes. All of these are responsible for the placental ischemia and the endothelial damage. Similar pathology almost exists even in case of preeclampsia, wherein we see that a lot of spiral artery remodeling issues occur, and then there is pro-inflammatory cytokines, which are released, IL-1, IL-6, etc. And we also see that these problems are reflected in very early when we look at biomarkers, especially with increasing S-FLT1, etc., which we will deal with a little later. And because of all this, the placental ischemia and the vascular remodeling issues, women end up with both these cardiometabolic problems, and these problems get carried on not only throughout their pregnancy, but also postpartum into their metabolic life in the form of future cardiovascular disorders, and also passing on the same cardiovascular problems to the neonates and offsprings.
Absolutely. The only thing which we are still not very sure is that there are maladaptation that we know, but we don't know whether those maladaptation are caused by a common pathway, whether the preeclampsia has got a different pathway to this maladaptation or diabetes has got a different pathway to this maladaptation. One thing now, more and more as more and more research is coming in, we know that it is the myocardial dysfunction that is ultimately responsible for most of the pregnancy disorders. I mean, preeclampsia is now being called as a cardiac disorder rather than a placental disorder. And placenta is supposed to be a victim and not the culprit. So we are reaching that stage almost, and both GDM and women with PE have similar impairment in the myocardial function in the third trimester. There are a lot of pathogenic contributors. Dr. Chaitra brought out a few, like the reactive oxygen species of the ROS, the nitric oxide, the cytokines. But mitochondrial dysfunction is taking an upper hand now, that there is some kind of a mitochondrial dysfunction which occurs both in diabetes and preeclampsia, ultimately resulting in both the disorders being existing together. And another very important, very interesting fact that I found was that there are advanced glycation end products, the abnormal end products of the glycolysis procedure, metabolism, results in this kind of end products which cause preeclampsia. And there are also what we call as the extracellular vesicles, which are some kind of a cell membrane vesicles which mediate crosstalk between placenta, adipose tissue, and the circulating blood cells. So this kind of a crosstalk, if something goes wrong, then both diabetes and the preeclampsia come in. Now, finally, bring in Dr. Tilak.
Yes, sir.
How do these two great disorders affect each other?
So they definitely affect each other, especially it can be a pre-existing diabetes or the gestational diabetes. It will definitely increase the risk of incidence of preeclampsia. So coming to the incidence, in a non-diabetic woman, the preeclampsia rates is approximately 2 to 7%, whereas in case of diabetes, it raises to 15 to 20% in type 1 and type 2, 10 to 14%. So the pathophysiology is already been discussed by Chaitra ma'am. So it's basically the two things. One is angiogenic imbalance, and there is something called as haptoglobulin phenotypic expression, especially in type 1 diabetes. Whereas in type 2 diabetes or gestational diabetes, it's mainly because of the insulin resistance. So this insulin resistance itself is a main risk factor, and it is a pro-inflammatory state. So which is going to increase the oxidative stress, onset of inflammation, then failure of uterine spiral arteries, which may all cause hypoxia, and this imbalance between reperfusion and ischemia will prone for to release certain placental factors, which increases the risk of preeclampsia. And since preeclampsia and diabetes share a common risk factors like based on maternal age, nulliparity, race, ethnicity. So definitely it is going to increase the risk of preeclampsia with the patient or with a woman with pre-existing diabetes or gestational diabetes.
Okay, so basically the diabetes through either through insulin resistance and through mitochondrial dysfunction will
Yeah.
cause impaired trophoblast invasion, which results in spiral remodeling deficiency, leading to the placental ischemia. The
Yes, yes.
neutrophil extracellular traps, the oxidative stress, and the TNF alpha and IL-6 add on to this insult. So ultimately, what happens is the S-split increases, the PLGF decreases, and finally you have the endothelial dysfunction leading on to preeclampsia. So this is the way both diabetes and the preeclampsia are connected to each other. Next question again to Dr. Tilak. What role does obesity play in the etiology of these two conditions?
And obesity is one of the major risk factor for both the conditions. So obesity, as we all know, it's an excessive weight gain. So not only the obesity, it's also the weight gain during the gestation. So which has to be matched according to the BMI in the preconceptional period. So since there are multiple pathophysiology like genetic predisposition or lifestyle, the sedentary lifestyle or the dietary regime, which ultimately leads to excessive weight gain. So this excessive weight gain is again resulting in insulin resistance, which is a pro-inflammatory state, which is going to cause hepatic steatosis, dyslipidemia. So then, which leads to a chronic inflammation, which it releases certain chronic inflammatory cytokinins like interleukin 1, 6, tumor necrosis factor alpha. So increase in leptin and decrease in adiponectin, which all results in the endothelial dysfunction and increases the risk of preeclampsia.
So absolutely, the obesity causes both a lipid profile alteration as well as an insulin resistance, and ultimately through the same cytotrophoblast migration, and ultimately leads to endothelial dysfunction, leading on to hypertension. What is more interesting to note is that the effect of pre-pregnancy BMI on preeclampsia in women with GDM is related to the blood glucose levels and the treatment methods. That means if we keep the blood glucose levels under control and if we use proper treatment methods, we may be able to bring down the incidence of preeclampsia in our diabetic patient. The next question to Dr. Revati Janakiraman. We have seen about obesity. Now, the way the woman gains gestational weight, does it play any role? You're muted, ma'am.
And it's muted. Okay. Definitely it has a role. We know the recommended gestational weight gain according to the pre-pregnant BMI. Okay. So for a normal or a obese or a severely obese, all those things. Okay. Or underweight also. And definitely overweight and obesity or increased gestational weight gain increases the risk of preeclampsia. And definitely optimal weight gain must be maintained in those patients. Definitely the incidence of preeclampsia can be reduced. So our aim should be to plan an optimal weight gain and advise them properly what are all the things like lifestyle changes or diet or exercise, whatever it is, so that they maintain the optimal weight gain. It is one of the measures to reduce the occurrence of preeclampsia.
Absolutely. The more important point to note is that if the weight gain increases by an excess of 0.45 kg per week, then the probability of preeclampsia increases by 83%. So let us all look very carefully at the gestational weight gain that our patients are gaining. I'm sure all of us check the weight, but unfortunately, many of us do not compare the weight as it was in the previous visit to the current visit. So let's make that a habit, because you will be able to pick up some of your patients who are likely to go in for preeclampsia. Dr. Tilak, does the type of diabetes, whether it is T1, T2 or GDM, influence the preeclampsia and its complications? The type of diabetes, does it have an influence?
Yes, sir. Overall, it's basically the type 2 and gestational diabetes is basically because of insulin resistance. So, whereas type 1, it has been observed that there is an increase in the factors. So, like which is there is an increase in anti-angiogenic factors when compared to angiogenic factors. It has been observed in type 1 diabetes. And also there is an expression of the phenotype in haptoglobin, which has been stated in case of type 1 diabetes, which is going to increase the risk of preeclampsia.
Absolutely. So the type of diabetes that the woman has is also important to assess whether this woman is going to get preeclampsia or not. The next question to Dr. Chaitra. Does HbA1c give any clues about this interplay? Is there any value of HbA1c which can tell me, okay, this diabetes is going to develop preeclampsia, this diabetes may not develop preeclampsia?
Yes, sir. I found about two studies, though a little older, wherein a cutoff of 5.9 was mentioned. So HbA1c higher than 5.9 definitely puts the woman at higher risk of preeclampsia compared to women lesser than 5.9 is what I could find in literature.
Absolutely. See, initially when we were looking at periconceptional HbA1c only from the point of view of congenital anomalies that would come in. I think it is time now we look at periconceptional HbA1c from the point of view of preeclampsia also, because the incidence is almost 10% more if the HbA1c is about 6.5%, and if the HbA1c is 9.1 just before conception, then the incidence of preeclampsia goes up to 22%. So this would definitely add on some information and some amount of clues for us to counsel the couple when they come to us. Next question to Dr. Narhari, please. Does early and adequate treatment of diabetes mellitus decrease the incidence of preeclampsia?
Yes, sir, true. Because if you go to pathophysiology, as we are discussing about the glycosylated hemoglobin, for an obstetrician point of view, if you are doing a glycosylated hemoglobin HbA1c, there are three reasons for it. Suppose a patient comes for a pre-pregnancy planning, and once you are doing some routine test, and if you get some altered, impaired glucose tolerance or HbA1c, what does it signify? It signifies there is some chronic metabolic things which is happening, which may have a cardiometabolic vascular risk factor in the subsequent part of the pregnancy. So definitely it has a correlation. So if you can counsel from the beginning about this cardiometabolic vascular dysfunction of this particular diabetes and preeclampsia, these are pathophysiology and pathogenesis correlated. So definitely we can reduce the burden, because what happens, there is a predictability and there is also some preventive factors, starting from pre-pregnancy weight loss, body changes, and also the sedentary lifestyle causes hamper to this, and also it is a etiological factor for both diabetes and hypertensive disease of the pregnancy. And coming to the dietary factor, exercise, and also certain pharmacological medications, we can start from the early so that we can reduce the severity of the complications and reducing the morbidity and mortality of both the diseases.
Absolutely. So early screening and active treatment will definitely reduce the risk of preeclampsia in this patient. Again, back to Dr. Narhari, what lifestyle changes are advised? What will you advise the lifestyle changes, and have you faced any challenges making the woman accept the lifestyle change?
Sir, honestly, confessing before you as a giant person in this field, it is very easy. It is very easy to tell, but it is difficult to practice.
Absolutely.
Lifestyle modification, it starts from bio-behavior, changes from exercise, dietary modification, and also workplace modifications. Now, you see, our young girls are much more well-versed and they're very much acquainted with electronic gadgets. And they're spending days and nights before the electronic gadgets and forgetting about the exercise. And what they're eating bean spoon. They're eating the processed foods. They're eating the junk food. And pizza, burger, all these things. And this causes most of the harm to the vascular organs. without understanding what is going on. And as of now, there is not a single ideal anti-obesity drug for this particular patient's particular domain. So that is another challenges for us. And the next thing is exercise. Yes, we have been taught and we have also seen, even if 6 to 7% of BMI decreases, it causes spontaneous reduction of this menstrual irregularities becomes oligovulation, becomes a normal ovulation. All this can happen, but to obtain, to have a continuous exercise, that is also a decimal, because what is the normal exercise? Every week, 4 to 5 days, at least 30 to 40 minutes of exercise should be done. But I'm really wonder, and I'm really not so much optimistic that if you go on advising our patients for regular exercise, how much they are doing, and we have not a measurable caliber to measure that. So that are the really difficult challenges, starting from counseling, and also the to whom you're counseling and whether they are obeying it or compliant, and also the particular the pharmacological agents. And Dr. Tilak can tell about the newer molecule which is now coming, GLP-1. And if it's a wonder, then the burden of this non-communicable disease starting from diabetes, preeclampsia, eclampsia can be much reduced. And I hope so in the recent future, one molecule may come that may act as a wonder and to reduce the body weight and reducing all the severity of this severity and complications of this dreadful non-communicable diseases. That's my honest confession.
Yeah, Dr. Narari, I always tell my patients when they ask about, doctor, give me something to reduce the weight. I said, if I had that kind of a medicine with me, I would have a line of patients which will be 100 miles long.
Yes,
so,
sir.
we don't have any such wonder drug. All the drugs
sir.
have been coming and going. Okay, we have to keep our mind open about whatever drugs are coming, keep their limitations in mind, and then only go ahead. But what would be more important is that prenatal vitamins are important both for diabetes and for preeclampsia. And we need to make sure that, especially the folic acid and the vitamin D are corrected in these patients prior to getting pregnant. And the more important point would be that the lifestyle changes in pregnancy should not be stopped. It should be continued in the postpartum period. And postpartum period is very challenging because that woman has got a small baby who doesn't allow her to sleep, doesn't allow her to eat. And you ask her to do 40 minutes of exercise when she's so tired. Obviously, she's not going to do what we are telling. But we have to keep up our efforts and make sure that at least a part of what we say is being followed.
True, sir. True.
Dr. Revati, the question to you, does metformin have a special role in this interplay?
Definitely.
By giving metformin and preventing both preeclampsia and diabetes?
Yes, definitely. Because, preeclampsia is closely associated with placental hypoxia, which increases the secretion of SFLT1 as well as soluble endocrine. Metformin has been found to inhibit these anti-angiogenic factors so that it might be a candidate to prevent or treat even preeclampsia. I just love this quote. Metformin is the aspirin of 21st century. Not only inhibition of these anti-angiogenic factors, but in many other ways also it acts. It modulates the nitric oxide pathway. It inhibits the secretion of the adhesion molecule by vascular endothelial cells. Thereby, it reduces the vascular injury. Obviously, it improves the insulin resistance. And also, definitely, we know that it reduces the gestational weight gain also, which we showed the importance in preventing the preeclampsia. So, by all these ways, definitely, metformin is the preferable one for preventing preeclampsia.
Absolutely, madam. Metformin is supposed to be the aspirin of the 21st century. What it does is metformin acts on the mitochondria on complex 1, brings down the reactive oxygen species, increases the AMP-activated protein kinase, and that causes a decrease in oxidative stress and increase in insulin sensitivity, ultimately controlling both diabetes and preeclampsia.
So given the choice, I think in GDM also, you prefer metformin rather as a first drug of choice rather than insulin.
Absolutely. So, and there is one more new molecule that has come in, which is called as rapamycin, which is a mechanistic target, and this modifies both the cellular hemostasis and energy disposition, so that ultimately both preeclampsia and diabetes come down. Dr. Chaitra, the role of biomarkers? Can
Yes,
I
sir.
use biomarkers to identify, worsening preeclampsia, worsening diabetes?
Yes, sir, we can. Even in the prediction of these diseases, to get that lead time, biomarkers play a very important role. So, pregnancy basically it's a delicate balance between angiogenic and anti-angiogenic molecules. So, molecules like transforming growth factor beta, then vascular endothelial growth factor, all these are very essential and for the spiral artery remodeling and the healthy placental development to happen. Whereas molecules which are anti-angiogenic, like SFLT1, when they increase substantially, then this is what leads to the pathophysiology of preeclampsia, as well as it is also noticed in women developing diabetes. Placental growth factor, or PLGF, is an angiogenic molecule, which is a beneficial molecule. So one of the most studied biomarkers that has been and which has also been in use even in India, and we are also using it, is SFLT PLGF ratio. So SFLT, the increase in SFLT and decrease in PLGF is not good. That means the SFLT PLGF ratio increases. It tells us that the woman is highly likely of developing preeclampsia. Well, we could diagnose these people after they develop the disease. So what is the advantage of biomarkers? Biomarkers, they manifest or they show the changes much before the disease manifests itself. And this is what is
Okay, I think we are facing.
So much earlier, almost 2 to 4 weeks earlier, we can see the changes in the use of PL. Sorry?
Yeah, I think there's some net
Hello?
issue, Chaitra. There's some net issue.
Hello? Okay, am I audible now?
Now you're audible. Please go ahead.
Okay, so I'm not sure how much I missed, but what I was trying to say is that the SFLT PLGF ratio is a very important biomarker. A rise in the SFLT levels and a drop in the PLGF levels. That means an increase in the SFLT PLGF.
All right, Chaitra, we got the point. We know it is important. So this is just one graph to show how split PLGF ratio in the third trimester behaves. Look at the control. It's almost at
tells us that the woman is highly likely to develop
goes a little higher.
Preeclampsia.
Yeah, Chaitra, we got the message. Whereas if you have a T1 diabetes with zero planning or zero control, then the split PLGF remains very high. So a use of split PLGF ratio can help us in identifying which diabetes are going to go for preeclampsia or worsening of preeclampsia in the diabetic. Same way we can use glycosylated fibronectin, although the glycosylated fibronectin values may change because the glycosylation is much more in a diabetic patient. Still, we can use it because if high values, if I get a value above 600 on a glycosylated fibronectin, then the patient has definitely a worse kind of preeclampsia. So the question to Dr. Tilak, management of combined disease, that is one
Yes,
I'd like you to answer. And are there any long-term effects, especially coronary vascular disease, affected by this interplay? We know
Yes, sir.
preeclampsia causes disease. We know diabetes causes disease. But if they are two together, is my chance of getting a coronary vascular disease higher?
Yes, sir. They say that preeclampsia will increase the coronary vascular, the events in future by fourfold increase when compared to a woman without preeclampsia. And they also say that if the person or woman develops preeclampsia, it has to be considered as the first major cardiovascular event. So, how to assess this? So, there are various, methodologies where the woman has to be subjected post pregnancy, like till 12 months after the termination of pregnancy. So, and we assess the future events by assessing certain things like pulse wave velocity, flow mediated vasodilation in brachial arteries, as well as carotid intimal wall thickness. So these are all the methodologies we use to assess for the risk for the future cardiovascular event in a woman. And basically, the pathophysiology is the endothelial function which happens in preeclampsia. It also states that during the preeclampsia episode itself, so there will be certain endothelial dysfunction in the microvasculation vasculature of coronary vessels in the heart, so which is going to predispose the woman for the events of cardiovascular events like stroke, can be a coronary artery syndrome, or heart failure in future. So coming to management, so it starts right from the preconception period. So we have to assess her HbA1c levels, thyroid status, so and the obesity, the BMI, and we have to give certain antioxidants like vitamin C, E, so which helps in reducing the evidence or incidence of preeclampsia in the preconception period. So once she conceives, she has to be educated about the proper weight gain in each trimesters of pregnancy. Then the life, of course, the lifestyle and the diet exercise diet changes which sir already discussed, so that has to be implicated if at all, if she develops gestational diabetes, which will be screened at 24 weeks. Then after that, if it is not recovering by 1 to 2 weeks with lifestyle modifications, then we will add therapies like metformin, which is basically used. So coming to GLP-1 analogs in preconception, the major drawback in India is especially because of the cost. So most of the individuals are backlogging because of the cost effectiveness, which costs around 3,000 per week. So a semaglutide single tablet, that too it's a 3 mg tablet, where by supplementing 3 mg of semaglutide, there will be no effect of weight loss.
Roughly 3 pizzas a week.
Yes. And that 3 mg has to be raised to 7 mg for its therapeutic effect. So so major drawback is the cost effectiveness in our the clinical practice. So in such cases, the metformin way plays an important role in decreasing the weight. So but actual guidelines says that the insulin is the only recommended the drug for the gestational diabetes. So, and also usage of ecosprin till 18 weeks of pregnancy has reduced the incidence of preeclampsia. So, yeah.
Yeah, sure. I think you brought out all the points very well. So, what we need to remember is navigating the pregnancy with diabetes and hypertension combined can be challenging, but with proper management and support, it is possible to have a healthy pregnancy, a delivery, and a healthy baby. So, let us all make sure that we manage our diabetics and preeclamptic combined with an absolute fervor. And effective CVD preventive programs are urgently needed in our country to improve the women's long-term health. Because most of the time, obstetricians forget handling the patient once she delivers. The patient doesn't go to a physician. So ultimately, she's left without any medical care. So I think as obstetricians, we have been talking about postpartum clinics. We need to have proper postpartum clinics so that we can manage these patients very well. So in conclusion, diabetes and preeclampsia are common pregnancy complications with similar risk factors and similar pathophysiological changes. The incidence of PE is significantly increased in women with GDM, but whether GDM is independently related to the occurrence of PE has remained controversial. GDM complicated by preeclampsia further increases the perinatal adverse events with great impact on future maternal and offspring health. Optimizing the treatment and management of GDM can reduce the incidence of preeclampsia, which will in turn improve the pregnancy outcomes. And identifying the controllable factors affecting preeclampsia and diabetes mellitus is important for improving pregnancy outcomes. I thank all my panelists for giving wonderful answers and bringing out the knowledge in a very good way. Thank you all very much. And thank you all the audience for patient hearing.
Thank you.
Thank you, sir.
Thank you, sir. Thank you.
Thank you, everybody. So I hope all of you have really enjoyed this. Some chat boxes, 1 minute, sir, just looking. Okay, Dr. Revti has questions. Q&A. Okay, so there's one question. Role of vitamin C and vitamin E in preconception and during pregnancy. I hope to prevent preeclampsia is the question for.
Vitamin D, of course, we know that the decrease in vitamin D can cause preeclampsia. So vitamin D correction is one of the methods that are now advocated, although it has not come into any guidelines whatsoever so far. Vitamin E, because it's supposed to bring down the reactive oxygen species, has been used, but we definitely don't have a full clear-cut evidence for it. So if I'm going to go strictly by evidence-based medicine, no vitamin E. Vitamin D, there is some evidence, and I need to make sure that the patient is requiring vitamin D before giving it.
The next question. Can 150 milligram low-dose aspirin be started in third trimester in type 2 diabetic pregnant women if not already started?
Well, aspirin can be used at any time. What we should understand is the effect of aspirin on prevention is going to be much lesser the later you use. Now, basically, aspirin, when we use it later, it is mainly to make sure that the platelet destruction, the platelet coagulation doesn't occur in the blood vessels. So to prevent the additions of platelets, we are using it, which may help in improving the vasculature, the vascular blood supply to the placenta. That's the only argument we have for using it late, because it's not going to change anything else. But since the lipid profile is abnormal, since there is a chance of greater platelet aggregation, we can avoid it. I mean, it may help, it may not help. But when I have got nothing in my hand, I have to use something what is available. And that's how we use aspirin at such a late stage.
So in hyperlipidemia, any hyperlipidemia common factor to be checked pre-pregnancy?
Hyperlipidemia.
I think because obesity was discussed at large because of it.
Hyperlipidemia is known to be associated with preeclampsia. Hyperlipidemia is also a result of abnormal glycolysis, which happens in diabetes. So that is how hyperlipidemia comes into the picture. Actually, about, I think, 18 years or 20 years back, lipid dysfunction was considered as one of the major theories for preeclampsia. And two of my students have done a dissertation on lipid levels in preeclampsia and normal pregnancy. And at that time also, we have definitely found that the lipid levels are higher in preeclamptics as compared to normal patients. But now how each is related to diabetes, what causes preeclampsia, they are still not very sure. Apart from that, the third factor has now come in, that is obesity. Obesity also results in hyperlipidemia. So by controlling hyperlipidemia, I may be able to control all these three disorders, is what has been said. And people have used statins to control preeclampsia. But again, after an initial enthusiasm, it has cooled down. So that is what same thing with, whether the GLP-1, we are so enthusiastic now. I do not know what the
answer is going to be after
5 years down the
road. So about vitamin E, you've already said that not required to be given. Vitamin C to be given, what dose and how long, if at all it helps?
That would depend. See, once you give vitamin D, generally what I use is
C for cat.
Vitamin C.
C.
Okay, vitamin C again, because it's a antioxidative agent. People have tried it. Definitely no direct evidence to say that it is going to help. And we have none of the guidelines are still saying we have to give vitamin C. So if you are giving vitamin C, if you have some clues in the patient history that you need to use vitamin C, go ahead and use it. But if you are going to use vitamin C as a preventive aspect of preeclampsia all the time, no, there is no evidence.
How to, Dr. Revati has already answered this question. How soon to start aspirin 150 mg in obese patient? Preconceptional, as soon as they conceive, or at 12 to 16 weeks. Dr. Revati has written as soon as they conceive.
Well, I would differ a little bit. I would like to start any aspirin only after the cardiac activity comes in. Because, these patients are at very high risk for abortion. And I don't want her to have a threatened abortion at the time she is on aspirin. Because abortion has got, abortion can be due to multiple reasons. So I generally wait for the cardiac activity to come in and then start aspirin. That's my personal way of handling.
Considering overlap of diabetes and PE, is there a role of starting metformin like aspirin in early pregnancy despite normal blood sugars?
Yes, one thing we should remember is that the metformin doesn't bring down the blood sugar level. It doesn't cause hypoglycemia. It can bring hyperglycemia to a normal level, but it does not cause hypoglycemia in the patient. So, like Madam Revati also said, and like what I showed on my slide, metformin is becoming the 21st century aspirin. We need to wait for a few more evidences to come in. But I wouldn't be surprised if you're going to use metformin to control both or prevent both diabetes and preeclampsia very soon.
So during preconception, sir, I think we should have one on obesity and PE.
I know we'll have one session on obesity, obesity and preeclampsia. Definitely we'll have one session in future, one VLS-PE.
So preconceptional counseling, should we do lipid profile and start statins?
So lipid profile, people have tried out statins, as I told you, have been given not only pre-pregnancy, but even during pregnancy to prevent preeclampsia or bring down the severity of preeclampsia. However, we still have no evidence for that. And more than any drugs, if you look at all the guidelines, lifestyle modification will do the most of the trick. So before using any drug, please spend some time with the patient. It's not very easy to convince a patient. Just yesterday, I had a patient who was 140 kgs. You know, I had to sit with her for half an hour and tell her what she has to eat and what she does not have to eat, apart from sending her to my dietitian. Because they don't listen to the dietitian. They listen to you a little more than they listen to the dietitian. So we need to spend some time with them. We need to have special clinics for that. And I think with more and more maternal fetal medicine specialists coming in across the country, I hope very soon these patients will be sent to maternal fetal medicine specialists for pre-pregnancy management also.
The dose of metformin is one question. And to summarize, what and when to give obese women to prevent GDM in pregnancy?
There has been no evidence again that I can prevent GDM by giving the pregnancy. Yes. There are articles that have started coming in that if I give metformin, it will be all right. And generally what I use is, I use a sustained release tablet because it gives a better control over 24 hours. And most of the time, 1 gram per day should be enough. But if she's obese, morbidly obese, then it has to be twice a day.
Can I add one point regarding metformin in prevention of GDM? Now, Dr. Seshi has studied it. They have shown that 2-hour postpartum blood sugar at 10th week of pregnancy, if it is more than 110, they are likely to develop GDM. So, prophylactically, we can start on metformin right at that time itself. So, that study is there to prove.
After 10 weeks.
And there are many other studies.
10 weeks, the PP sugar must be less than
China, especially from China. There are a lot of studies that have come in where they have used metformin for GDM control. I mean, GDM prevention rather. But, you know, we are still not in a stage where we can say unambiguously that use metformin to prevent diabetes. It may come in the next few years.
So for both prevention of preeclampsia as well as diabetes, metformin as a drug of choice may come soon in the future.
We may not use aspirin anymore. We may use only metformin to prevent both together.
Yeah. 2 in 1.
Yeah. Thank you all very much for
thank you very much.
Wonderful panel and a very patient hearing. And thank all our audience who are seeing us on the real time or who are going to see us in future on the YouTube. Thank you all very much for being a part of this program.
Thank you. Thank you.
Thank you, everybody. It's my duty and responsibility to render the vote of thanks to all of you. First of all, to Sir Dr. Prakash Mehta and to Dr. Revati for being the brain behind this program and to include all of us to be an active participant in running the VLS series as a part of PENI project. Thank you to Dr. Kenneth Shen. Sir has already logged off. We have expressed our thanks to him for bringing about an eye-opening topic into this lecture series, the use of GLP-1 receptor agonist in the role of preconceptional risk modification. Thank you to all our panelists, Dr. Revati Janakiraman, Dr. Tilak, Dr. Narahari, and Dr. Chaitra, who gave their wonderful insights into managing diabetes and pregnancy with preeclampsia as a combination. It was wonderful listening to all of you. Above and beyond, I would like to thank the Shield Healthcare Private Limited, who has been helping us run this program, who has been our thorough supporters in running this program, especially the Vice President, Mr. Balaji, and Ganesh, the Regional Coordinator, along with our dear Sahiti and Chitrakala, who are been great support in making sure that the program runs without any hiccups. I would like to extend my greatest of thanks to Mr. Srikanth Rajgopal and Ms. Pramila Bhatt, working from the SFIMI office to make sure that there are no hurdles that we pass during the program. It has been wonderful. Thank you mostly to the listeners of this program. I would like you to be part of us for the upcoming programs also. We have a list of another 4 more coming up in this season. Today's program will be available on YouTube in a short while. We will be providing you with a link of the same. If you have missed it, we'll see you soon as through a YouTube link. Thank you so much.
Thank you all. Thank you. Thank you, Anu.
Thank you.
Thank you so much, sir. Thank you, Shield.
Have a nice
you,
day.
everybody, and have a great
Have a
Sunday.
good day ahead.
And
Let's
Dr.
stay
Bhatt,
connected.
Thank you, everyone.
wonderful webinar. Thank you.
Thank you, Dr. Revati and sir.
Thank you.
Thank you.